Hello. Good morning, good evening, good afternoon to everyone. Saurabh,
Hey, how are you?
thank you so much, Professor Bukhari from Pakistan.
Uh, okay, so we are live. Good morning, everyone. Today is 23rd of May, 2026. We are live on yet another session, which is very important session for the world. We are talking about the global fight against HIV, AIDS, progress gap, and future goals. This session will provide a valuable insight on what we have achieved so far, what are the current challenges, and the road ahead. To talk about this topic, we have Dr. Glory Alexander, President of AIDS Society of India, Founder Director of Asha Foundation. She's a Dr. B.C. Roy Awardee and International Ashok Fellow. With decade of contribution to HIV and AIDS care, prevention, and women health, she has played a major role in advancing the awareness of support services in India. Please welcome Dr. Glory for the wonderful session. Ma'am.
Thank you. Good morning to all of you. I bring greetings from the AIDS Society of India and from my organization, Asha Foundation. At the outset, I would like to thank you for this opportunity to speak on this topic at this webinar. So the topic is the global fight against HIV/AIDS, the progress, gaps, and future goals. I have divided my talk into these three sections. The first section is that the progress that has happened thus far, and I'll be talking about the progress in statistics, the progress in treatment, in prevention, in cure research, and in vaccine research. Gaps, I'll be addressing the scientific gaps, social gaps, funding gaps, lack of community involvement, and the gaps that happen when disaster strikes. And with regard to future goals, from control to elimination would be the future goal, how to integrate it into existing health systems, the use of AI, how important partnering is, to keep a watch on our moral compass, and the call to action. So, what is the progress in statistics? So according to UNAIDS, and we have statistics as of 2024, there are 40.8 million people living with HIV. And in the year 2024, there were 1.3 million new infections. From the beginning of the epidemic, about 91.4 million people have been infected with HIV. And so far, about 44.1 million people have died from HIV. If you look at the progress that has happened over the last 2.5 decades, you will see that people living with HIV has gradually increased from 27.9 million in 2000 to 40.8 million. And this is because of the treatment that is available and people are living longer. So you have more people living with HIV. New HIV infections have reduced from 2.9 million in 2000 to 1.3 million. AIDS-related deaths have also reduced from 1.8 million to 630,000 in 2024. People accessing ART or antiretroviral therapy has gradually increased. And from 370,000, today we have 31.6 million people all over the world receiving ART. The United States has been a major source of funding for AIDS programs globally. And they started out with providing about 5.1 billion in 2000, which increased to a maximum of about 21.5 billion in 2020. And then it has come down now in 2024 to 18.7 billion. Looking at the regional data, I'm just focusing on Asia and the Pacific. Currently, there are 6.9 million people living with HIV. There were 300,000 new infections in 2024, out of which 290,000 were in adults and 11,000 were in children. And 150,000 deaths occurred in 2024. Africa continues to bear the burden of the epidemic, and a large portion of Africa, as you can see, Eastern, Southern, Middle East, North, Western, and Central Africa are all bearing the burden of HIV with high numbers of people infected with it. So what has the progress been? The new HIV infections have reduced by 61% since the peak in 1996, And if you take 2010 as the reference point, then it's declined by 40%. And new HIV infections in children have declined by 62% since 2010. AIDS-related deaths have been reduced by 70% since the peak in 2004 and by 54% since 2010. In 2024, there were 630,000 deaths from HIV. The target actually is 250,000, so we didn't hit that target. And AIDS-related mortality has decreased by 58% among women and girls and by 50% among men and boys since the reference point of 2010. HIV prevalence among adults globally in the general population is about 0.7%. However, there are certain groups where the risk factors are high, and these factors, compounded by marginalization, discrimination, and in some cases even criminalization, has resulted in a higher seroprevalence among certain groups of people. So when we look at gay men and other men who have sex with men, the seroprevalence is high at 7.6%. Among sex workers, it's 2.7%. Among people who inject drugs, it's 7.1%. Among transgenders, it's 8.5%. And among people who are incarcerated in prisons, it's about 1.4%. Women and girls, 45% of all new infections were among women and girls. And in sub-Saharan Africa, women and girls accounted for 63% of all the infections. Rest of the world, it was the boys and men accounted for 73% of new infections. And every week, 4,000 adults and girls and young women aged 15 to 24 years became infected. A majority of them were in sub-Saharan Africa. Treatment strategies, you're all familiar with 95, 95, 95, the targets to be reached by the year 2030. What does it stand for? 95%, the first 95 stands for 95% of those estimated to be living with HIV should be aware of their status. The second 95 is that 95% of people who are aware of their status should be placed on antiretroviral therapy. And the third 95 is 95% of people who are aware of their status should be virally suppressed. And the fourth 95, which is not mentioned here, is that 95% of people should be, who are aware of their status and on treatment should have a good quality of life. If you look at this bar graph, just focus on the bar graph on the right in yellow, 87% of people estimated to be living with HIV are aware of their HIV status. 89% of that 87% are accessing treatment, and 94% of that 89% are virally suppressed. That's on the right. If you look at the left, 87, the blue graphs, 87% of people are aware, or 87% of people estimated to be living with HIV are aware of their status. 77% of those people living with HIV are accessing treatment, and 73% of the people estimated to be living with HIV are virally suppressed. I hope you understand the difference between these two. This bar graph on the right talks about only those who are aware of their status and those who are on treatment from that 87%. Whereas here we are talking about the whole HIV population. What has been the progress in treatment? The biggest change that has happened is that HIV has changed or transformed from a life-threatening fatal illness to a chronic manageable illness, just like diabetes or hypertension. So we have changed from a death sentence to chronic care. And the single most important reason for this transformation is ART, or antiretroviral therapy, which has transformed survival. And today we have people living for 25, 28, 30 years with HIV and leading a good quality of life. And then there has been prevention tools expanded, pre-exposure prophylaxis, prevention of mother-to-child transmission of HIV, and the concept of U is equal to U, about which I will talk later. Also, involving the community in the management of HIV has changed the stigma narratives. The message we have from this slide is we have bent the curve, but not ended the epidemic. This slide shows you the number of drugs, the words in brown above the blue bar line, all show you the number of drugs that have been developed over the years from 1987 right up to 2017 and beyond. There are more than 35 drugs that are available now for the treatment of HIV. If you look at the drugs towards the right of the slide, say from 2011 onwards, rilpivirine, dolutegravir, tenofovir, alafenamide, bictegravir, doravirine, these are drugs which are currently being used for the management and treatment of HIV. There are a few more drugs here which are not mentioned, which were developed much later. The drugs on the left, the whole bunch of drugs on the left, are also drugs which have been developed over the years, but which are toxic, which had a lot of side effects, which had a very low barrier to resistance. Whereas on the right, we have drugs which are safe to give, which have very few side effects and which have a very high barrier of resistance. So the treatment has improved with time. The efficacy of the drugs has improved with time. The side effects has improved with time. So today, these are the drugs that we use mostly in the management of HIV. If you look at the drugs that are outlined or highlighted in yellow, that's the commonest combination that we use. As we know for HIV, we do not give a single drug, we give a combination of drugs. The widely accepted treatment is a combination of 3 drugs. The commonest, as per WHO guidelines, is tenofovir, lamivudine, and dolutegravir, which is given. You can also give tenofovir, emtricitabine, and dolutegravir. You can give TAF, which is a milder version of tenofovir with less bone effects and less kidney effects. Lamivudine, emtricitabine, abacavir, and zidovudine are alternatives. Doravirine, the ones that are highlighted in purple, are alternative drugs that can be given if you cannot give this first line. And the 2 drugs that are outlined in green, rilpivirine and cabotegravir, are injectables. So yes, now we have injections also available for the treatment of HIV. And these are drugs which are given together, only 2 drugs, not 3, and they need to be given intramuscularly every 2 months. So for treatment, it's just 6 injections a year. Lenacapavir, the drug that is highlighted in gray, is a huge landmark drug that was developed in the year 2024. Currently, it is being used for prevention of HIV. The wonderful thing about this particular drug is that it's an injection and has to be given. It has a very, very long half-life of 6 months. So you need to give just 2 injections a year. So 1 injection every 6 months for a whole year provides almost 99 to 100% protection against acquiring HIV. So it's a prevention drug that it's being used for. It can also be used for treatment in cases which are complicated. So what are some of the newer concepts that have happened in ART over the years? So initially, when we started treatment for HIV way back in 2000s, 2003, 4, etc., we used to give 2 tablets, 3 tablets twice a day, or 2 tablets twice a day. So the number of tablets were 4, 6, or 8, depending on what medication, what medicines we gave. And a patient had to take a lot of tablets every day. But then one new change which happened is that all these 3 drugs are today available in a single tablet to be taken just once a day. So that's what we mean by single tablet regimen, 1 tablet a day at the same time every single day for the rest of your life. That's what the treatment has now been reduced to from what it used to be before. Test and treat policy, what is this? Before, we used to give treatment, start the treatment only when the CD4 count was approaching 250. Later on, WHO raised the threshold to 350 and later on to 500. And that was because the drugs were so toxic and you had to kind of strike a balance between the toxicity of the drugs and the danger of impending advanced HIV or AIDS. But now what we do is the minute we diagnose a patient, we confirm the diagnosis, we do a baseline viral load, we do a baseline CD4 count, we do baseline investigations, and we start the patient on treatment. We don't care what the CD4 count is, as long as it's normal. And as early as within a week of diagnosis, we start the treatment. Sometimes we start the treatment on the same day, especially if it's a pregnant woman who's being diagnosed for the first time in pregnancy. Also, before they use, that is what we mean by test and treat policy. Uniformity in treatment. Before, we used to have different medicines for adults. We used to have different medication for women living with HIV who are pregnant. We used to have different medicines for children. But now the treatment has been standardized and is uniform across all groups. And it is TLD, tenofovir, lamivudine, and dolutegravir. Before, CD4 count used to be the test that we would do to evaluate how the patient was doing from the point of view of immunity and HIV. But now we depend more on viral loads. So for every patient newly diagnosed with HIV over the last 4 or 5 years, we've been doing the viral load as the first test. And then we start the patient on treatment. And these drugs are so effective that within 3 to 6 months, they become undetectable. And what do you mean when we say undetectable? If the viral load is less than 200 copies, such a patient is referred to as undetectable. And you can use whatever viral load assay, but the cutoff value is 200 copies. So if the copies are less than 200, this patient is as a patient with an undetectable viral load. And several studies have shown that a patient with an undetectable viral load, even if he has unprotected sexual contact, he will not transmit the infection. So undetectable is equal to untransmittable, or U is equal to U. And therefore, treatment has also become a form of prevention, because if a patient has an undetectable viral load on treatment, then that patient will not transmit, even if he has undetectable, as long as he has an undetectable viral load. And even if he has unprotected sexual contact, he will not transmit HIV. The other thing is, from 3 drugs, we have now reduced to 2 drugs. In many cases, we can give 2 drug regimes, which is dolutegravir and lamivudine. So in patients who have a viral load that has become undetectable on 3 drugs, you can change them to 2 drugs and watch them and follow them up. And of course, we have injectables, which were not available before, but are now available. Cabotegravir and rilpivirine comes as a co-package, and you can give it every 2 months. Of course, now because people are living longer, they are aging, and we need to check them out, screen them, and they all have chronic inflammation. We need to check them for non-communicable diseases like diabetes, hypertension, cardiovascular disease, hyperlipidemias, cancers, etc. Self-testing for HIV is a new concept where a person who's at risk is taught how to test for HIV himself in the privacy of his house, along with counseling that can be provided online and a video which can show how to do the HIV test. Taken off in some countries, but not really taken off in India. So what are the 3 categories of viral load levels? Undetectable, as I mentioned, where there is the viral load is less than 200 copies. Usually, they have done studies on 152,888 couples, both heterosexual and same-sex couples, and found that there was 0 risk of transmission. However, in CROI 2026, that is the Conference of Retroviruses and Opportunistic Infections, which happened in Denver in 2026 this February, they did find in the Rakai study of Uganda that at 200 copies, there was a risk of transmission of 0.6% over the following year in an uninfected partner. And they also found, earlier it was said, that if a person has a viral load between 200 to 1,000 copies, we refer to that as suppressed. Risk of transmission is negligible. But again, at CROI, the Rakai study showed that in a couple of patients at 1,000 copies per ml, the risk of transmission was 2.9% over the following year, which was definitely not negligible. And unsuppressed is when the viral load is more than 1,000 copies. These are people who can transmit the infection to others. What are some of the drugs for the future, which are still not available, but which are in the pipeline? One is this drug called doravirine with a combination of islatravir, This is once a day pill, which is just 2 drugs. And that is why the option of using another 2-drug combination in addition to dolutegravir and lamivudine. Then we have this phase 3 artistry study 1. There are lots of patients who have been on treatment for a long period of time and have gone through the whole gamut of drugs from day 1 right up to now. And many of them may be on complex regimes. And these patients, they have found, this study shows that these patients can be shifted to a 2-drug oral combination of bictegravir and lenacapavir given orally, once a day pill, just 2 tablets in one tablet, just 2 drugs in 1 tablet. This study, the average age of the patients in the study was 60 years, and the average duration of treatment was 28 years. And they found that this 2-drug combination was very effective to control to maintain viral suppression. Then we now have drugs which can be given just once a week. So switching a patient on dolutegravir or bictegravir, taf or tenofovir, or emtricitabine lamivudine to once a week islatravir and lenacapavir also maintain viral suppression. So instead of looking at a drug every day, we are looking at a tablet every week. So at the end of 1 year, the patient would have taken 52 tablets for the control of HIV to maintain this viral suppression. Long-acting investigational drugs are being investigated. They are now VH499, VH184, GS3242, all are being investigated for giving just twice a year. So just 2 injections in a whole year to control HIV. And then the broadly neutralizing antibodies, they are being investigated in great detail, both for prevention as well as treatment, as well as vaccine production for HIV. So that has been some of the progress in treatment of HIV. What has been the progress in prevention? So if we look at, there are 3 main things that we look at: pre-exposure prophylaxis, post-exposure prophylaxis, and prevention of mother-to-child transmission of HIV. Post-exposure prophylaxis, again, has been standardized as uniform now. If a patient has any kind of risk, either occupational or sexual, and is worried about acquiring HIV, you do their baseline HIV test and put them again on PLD, the standard treatment, 1 tablet a day for 28 days. Repeat the HIV test at 6 weeks and 3 months. So now what is PrEP? These were the older prevention methods that we would talk about: abstinence, behavioral change, communication, where they decrease the number of partners, or they will use a condom consistently and correctly, the development of female condoms, vaginal diaphragms coated with tenofovir gel, and voluntary medical male circumcision, all of which were methods to decrease the risk of transmission. But today we have what is called as PrEP, or pre-exposure prophylaxis. PrEP is used by people who do not have HIV, but are at high risk of being exposed through HIV, through sex or injection drug use. And here you give them a tablet which is taken even though they do not have HIV, but you put them on this tablet, which reduces the risk of getting HIV from sex by about 99% and from injection drug use by at least 74%. And the key for these statistics is adherence. In PrEP, the idea is that it protects against HIV during sex without usage of a condom, but it does not protect against sexually transmitted infections. So we would really advise using PrEP and condoms together. So these are the 6 HIV medicines sanctioned by WHO for use of as PrEP. So I was talking about PLD. So only the TL part of PLD is used as PrEP. So you use only 2 medicines, tenofovir, emtricitabine as a single tablet taken by mouth every day, or tenofovir, alafenamide, and emtricitabine used as a single tablet. Lamivudine can be used in the place of emtricitabine. So basically, it's just 2 drugs, tenofovir or tenofovir, alafenamide, and emtricitabine or lamivudine. Dapivirine vaginal ring is a silicone ring that is coated with dapivirine and inserted into the vagina and gives 50% protection against acquiring HIV. Injection cabotegravir, which is used for treatment, can also be used for prevention. It's given intramuscularly by a healthcare provider, shot taken every 2 months. Injection lenacapavir is given subcutaneously by a healthcare provider, taken every 6 months. So these are the drugs that are currently available for pre-exposure prophylaxis. This particular graph shows you a series of studies that have been done in different groups of people, especially same-sex couples and heterosexual couples, to study the effect of oral PrEP. And as you can see, it varies from 44% up to 99%. A lot of it depends on adherence. There are two studies here, the FEM and the voice study, which shows zero efficacy. And that's because the women were really not adherent to medication. They didn't seem to understand. Both of these are studies done in women, one with oral tablets and one with the tenofovir gel vaginally. And studies showed that they were not really taking the tablets or the gel because the drug levels were like zero. But in the others, you can see that there is good efficacy of this drug. The HIV Prevention Trials Network 083 and 084 compared the injections against the oral tablets. And 083 was a study done on MSMs and transgender women in 6 countries all over the world. They compared TDF and FTC to long-acting cabotegravir and found that cabotegravir was 66% more effective. 084 study was on cisgender women done in 7 countries, only in Africa. And here they found that the long-acting cabotegravir was 89% more effective than oral PrEP. And these are 2 landmark studies, Purpose 1 and Purpose 2, which were published in 2024, where they gave this injection lenacapavir to women in the first study, Purpose 1, and to cisgender men, transgender men, and women and non-binary people in Purpose 2 study. And as you can see in the first graph, in people who were on oral PrEP, they were 39 infections and 16 infections. Background incidence was about 2.41. But look at this, lenacapavir was 0. In 44 weeks, they did not find a single person who acquired HIV after receiving this lenacapavir. Now, the 96-week study has shown a couple of cases, but still very, very significantly controls HIV, acquiring HIV by using this injection. And in the Purpose 2 trial, it was found to be, it reduced infections by 96%. So lenacapavir injection twice a year is a very effective drug for prevention of HIV in people who are at risk. So you know that injection cabotegravir once in 2 months, lenacapavir once in 6 months. How do you give oral PrEP? Oral PrEP can be given in 2 ways. One can be event-driven PrEP or demand-driven PrEP, where a person decides that he's going to have sexual contact in the coming week. So 24 hours before sexual contact, he takes 2 tablets of TL, tenofovir lamivudine. And then after sexual contact, 24 hours later, 48 hours later, he takes one tablet, and that's it. A total dose of 4 tablets for that particular event. But if he decides to continue having sexual contact, as over here, then he continues to take the tablet every single day till he decides to stop having sexual contact. So once he stops having sexual contact, he continues the drug for 2 more days and then stops. So this is event-driven PrEP. The daily PrEP is when people have continuous sexual contact with different partners over a period of time. Then you take the tablet for 7 days before you start sexual contact, and then take the tablet for as long as you are having sexual contact, 1 tablet a day. And then if you decide to stop sexual contact, say for 2 months or 3 months, you continue taking the tablet for 7 days without sexual contact, and then you stop the drug. Then again, maybe 3 months or 6 months later, if you decide to again have sexual contact, you can go back to start taking it. So you can take several courses a year depending on how your sexual contact has been. Coming to prevention of mother-to-child transmission of HIV, the risk of transmission without treatment is 15 to 45%. ART is highly effective. If ART is started for the first time when the patient is already pregnant and positive, the risk of transmission can be reduced to less than 5%. If she is already on ART and the viral load is undetectable and then she becomes pregnant, the risk of transmission is less than 0.1%. Now they're trying to integrate HIV with syphilis and hepatitis B. So every patient being tested for HIV should also be tested for syphilis and treated accordingly. It's always been an issue of formula feeding versus breastfeeding. In developed countries, formula feeding is what is advocated. But in low and middle income countries, we still advocate breastfeeding. And if the viral load is normal, then undetectable, then you can have a normal vaginal delivery. At Asha Foundation, we treat about 40 pregnant mothers with HIV every year. And over the last 12 years, we haven't had a single case of a child being born with HIV. So this treatment is very effective. 90% of our women made an informed choice to go for breastfeeding. So it is a very impactful program. The WHO has certain criteria for deciding which country can be a country that has eliminated mother-to-child transmission of HIV, or EMTCT, and 21 countries around the world so far have been validated by WHO for PMTCT. This is a slide that shows how HIV was horizontally transmitted from husband to wife, and then vertically transmitted from the wife or mother to the child during her pregnancy. The child grew up with us, became an adult. Viral load was undetectable on treatment. She got married to a man who was also living with HIV, but was undetectable. She became pregnant. She delivered a baby that is HIV negative and now about 4 or 5 years old. So in the third generation, you can halt the HIV in families. So first is horizontal transmission, then vertical transmission, and in the second vertical transmission, the infection can be halted, which is very impressive. Progress in cure research. As we all know, it's very difficult to find a cure for HIV. And why is that? One is because of latent reservoirs. There are many viruses which go and settle in certain cells in the body where they become latent, where they go to sleep. And they just stay there quietly for years and years. The patient is on ART, these viruses continue to be latent. But once you stop the treatment, these viruses wake up, they begin to multiply, they go into the bloodstream, and there is a viral rebound. So that is the latent reservoirs and one of the problems about treating those latent reservoirs. Also, these drugs multiply, these viruses multiply very and keep changing their surface proteins, so the antibodies can become ineffective against them. And because of the rapid mutation, again, finding a cure or a vaccine is difficult. And of course, HIV attacks the immune system itself, which is supposed to actually destroy the virus, but the immune system itself is being destroyed by the virus. So where do you find these latent reservoirs? They are found in the resting memory CD4 cells. They are found in mononuclear macrophages, in dendritic cells, hematopoietic progenitor cells, and in the astrocytes. And these cells are found in tissues like the lymphoid tissue, lymph nodes, spleen, adenoids, tonsils, gut-associated lymphoid tissue, in the CNS and microglia, astrocytes, in tissue macrophages, dendritic cells in the skin, in the genital tract, and in the bone marrow. So what are some of the cure research that has happened so far? When we look at long-acting ART and all these drugs that are being developed to be given only twice a year, that itself would be a cure because we're just giving 2 injections a year, and a lot of drugs are being developed and are in the pipeline now. Gene editing or CRISPR-Cas9 trials, where you cut off that integrated HIV DNA out of the host genome and preventing the virus from replicating. Stem cell transplants, we have had about 12 patients or 13 patients who developed leukemia and who were given donor transplants, stem cell donor transplants from donors who carry a genetic mutation at CCR5 delta 32, which is naturally resistant to HIV. And therefore, when these patients received these stem cell transplants from such donors, they became naturally resistant to HIV and HIV was controlled. But of course, you can't do that for the general population. How do you eradicate this viral reservoirs that I was talking about? One method is shock and kill. Using drugs, you shock those viruses into awake, make them awake, and then when they get into the bloodstream, you kill them, not being effective. Immune system can destroy. That's when you kill, block and lock, you push them into deeper latency, and then you lock them up so that they cannot be released. That has also not been successful. mRNA technology, using lipid nanoparticle delivery systems to coax dormant cells out of hiding. BNAbs, Even now, studies are going on in CROI 2026. They showed the use of two BNABs, which showed some potential to delay viral rebound. Study is ongoing. BNABs used in children and infants also to maintain remission after stopping ART. Looking at tissue-specific treatments where HIV can hide in immune cells in the brain, and you kill those cells using cancer drug BLZ 945 to see if it can effectively deplete these virus harboring cells without harming healthy brain tissue. So these are some of the cure research studies that are going on. Unfortunately, none of them has been very successful. Progress in vaccine research, germline targeting, where you do sequential priming shots to trigger naive B cells to produce BNAbs, started in December 2025 by the International AIDS Vaccine Initiative. It's an ongoing study. mRNA technology, various combination of proteins that closely resemble the virus to prompt cellular and antibody responses. Same technology that was used in COVID-19 vaccines. Mosaic vaccines, where you use a combination of genetic sequences from various viral strains, HIV viral strains. This study was stopped in 2023 because it was not making a difference. Viral vector platforms, where you use modified adenovirus to deliver HIV genes into the body. This again, in Covishield, they used adenoviruses. So this is another ongoing study that is happening. Again, not being very successful as far as vaccine research goes. What are the gaps? What are the scientific gaps? New infection persists. Even though the target for 2024 was 250,000 new infections, we had 630,000 new infections. So new infections is a reality. How to reduce the new infections is something that we have to look at. Late diagnosis remains high in many parts of the world, especially in low and middle income countries. Late diagnosis remains very high. We get lots of cases of advanced HIV, and there you may lose the patient because of the complications. PrEP, though highly effective, is not being used widely in many parts of the world. The Western world uses it. Some of the Asian countries uses it, but in countries like India, it's not really taken off. We have to think about the rising NCDs because patients are living longer. My oldest patient is 84 years old, and we have to screen these patients and handle their diabetes, hypertension, cardiovascular disease, hyperlipidemia, whatever else they have. So we go back to multi-pharmacy where we have to give them more tablets than what they were taking. And of course, all the problems of aging, like frailty and sarcopenia and things like that have to be handled. And of course, cure is elusive, vaccine is elusive. What is the social reality? Gender inequities persist. As you can see, women continue to bear the burden of the epidemic, especially in African countries, low and middle income countries. The the risk populations remain vulnerable. They are stigmatized, they are criminalized, they are marginalized, and so their access to treatment is reduced considerably. So that is a big issue. There's a big difference between have and have-nots. Equity, where there is fair distribution of all resources, is not happening. And that is something that has to be looked at. Funding fragility, always been a problem of acquiring adequate drugs, adequate finances for handling the HIV problem globally. And this has become worse with in recent years. Health insurance, in many countries, people living with HIV are not given health insurance. Funding concerns, there is volatility in international assistance. There has been over-reliance on external funding. There is insufficient domestic funding. Challenges in reaching key populations because when there is a dearth of finance, then the first group of people that are affected become the people highest at risk. And of course, because we should look at integration into health systems that are already existing so that you can reduce the amount of money that is being used. Funding issues, if you can look at this slide, globally, we require at least 21.9 billion annually by 2030 to stay on track to end AIDS as a public health threat. But what we have is just 18.7 billion. 52% of all funding is required from domestic sources. but only was increased by 2.2% in 2024. And then when COVID-19 happened, a lot of funding resources went from HIV to COVID naturally because that was an unprecedented epidemic. But HIV did suffer adversely because of it. Only 26 out of 61 countries have reported plans to increase their domestic HIV budgets by 2026. And PEPFAR, President's Emergency Plan for AIDS Relief given by USA for African countries, was cut. There's a 17% funding gap, and again jeopardizes the progress towards the 2020 global targets. What are the other unexpected realities we have to remember? Other pandemics like COVID-19, disasters like earthquakes and floods, war. During all of this, there is a decrease in resources, there is migration, and people don't have access to health service, and that makes things more difficult. We have to remember that the community is not a footnote, especially for people living with HIV and key populations or vulnerable populations. There is so much about them that we do not know. And because we stigmatize and marginalize this group of people, they do not trust the health system at all. The only way that we can reach across to these people is to empower the community itself so that they can become peer navigators. The people living with HIV have very strong networks, and these people can be empowered to help not only to reach out to these vulnerable populations, but also to identify. They can be used for identification, for counseling, for drug distribution, for treatment, for follow-up, for monitoring. They are a very useful resource which is not being used to the best ability possible. Research is another area where the community itself can give you ideas on where to do research and what type of research to do and how to monitor research as well as programs. Self-testing by the community itself is something else that needs to be considered. As you know, nothing about us without us is what the community is saying. We need to stop the top-down approach and treat the community not as beneficiaries, but as equal partners. Decision and AI is now very important. Artificial intelligence can play a huge role in public health. We are talking about AI-enabled surveillance, where we can analyze electronic health reports, lab reports, other data, which can help us to identify hotspots, flag undiagnosed cases, and track disease progression. Mobile health adherence tools like SMS reminders, smartphone apps, digital pill dispensers, which dispenses your drug at the correct time with a reminder, and this is remotely logged on in a cloud platform. So the patient, so they can be monitored at the same time. Data-driven micro-targeting, public health surveillance, spatial data, and machine learning to identify specific subpopulations and hotspots. Real-time dashboards which allow healthcare workers and policymakers to monitor disease trends, track progress towards viral treatment goals. But in all this, where there is a lot of intimate data being collected, we have to ensure that ethics are maintained, privacy is maintained, and community trust is maintained. So what are the three shifts for the next decade? From control of the epidemic to elimination of the epidemic, we have to change our mindset. From program delivery to health systems integration, and from treating the community as beneficiaries to treating them as equal partners so that they can help not only in handling the HIV epidemic, but can also be brought to the table and be involved in decision-making and policy-making. This last slide is a very crowded slide, but it's the HIV targets towards 2030 and gives in more detail what I've spoken about very briefly. This is the global planning strategy from the years 2026 to 2031. As you can see, integrating services and systems, 95% of people receiving HIV prevention should also be integrated into sexual reproductive health services, into vertical transmission along with syphilis, hepatitis B, should be screened for hepatitis C, should be screened for cervical cancer, should be screened for non-communicable diseases, should be screened for mental health disorders, and there are and the target is at least 90 to 95% of people living with HIV. resourcing the HIV response, moving from outside funding, external funding to internal funding, and looking at innovative methods of raising funding in your own countries to handle the HIV epidemic. India today is dependent on its own funding. We are not dependent on outside agencies, and India has been giving free ART from the year 2004 till now continuously to almost 1.8 million people living with HIV. So that is one example. Then preventing new infections so that 95% of people who are at risk of acquiring HIV infection have knowledge about HIV, have prevention options like PrEP, PEP, condoms, needle syringe programs, opioid agonist treatment, etc. 90% receive comprehensive sexuality education, 80% use condoms, 95% use condoms. All of these are different targets that have been placed for the various types of treatment or prevention that needs to be done. And of course, lifting barriers of stigma, gender inequalities, and ensuring human rights, all of these need to be reduced to less than 10%, which seems to be so difficult at this point in time, that there is less than 10% punitive laws and policy environment, that there's less than 10% stigma and discrimination against people living with HIV. There's less than 10% gender inequality and violence against women. And then 80% of prevention options to be provided by community-led organizations, 60% societal enabler programs to be delivered by community-led organizations, and 30% testing and supportive treatment to be provided by community-led organizations. And of course, 95, 95, 95, I've already talked to you about that. So by 2030, reduce new infections by 90% from reference point of 2010, and then further reduce by 5% every year after 2030, reduce AIDS-related deaths by 90% from 2010, and have a sustainability of the HIV response after 2030. The moral compass, the next decade, is not only about biomedically controlling the infection, it is also about dignity, it's about equity, equality, non-discrimination, gender justice, and youth empowerment. Closing message, the HIV response has been one of humanity's greatest public health achievements. The progress is real but unfinished. Equity, dignity, and sustained investment must guide the future. And the goal is not only ending AIDS, but ensuring that no one is left behind. Thank you for your attention. Hello?
Hi, can you hear me?
Yeah.
Yeah, hi. Thank you for the wonderful session and insightful session about HIV, AIDS, where we stand today, what's the progress, what's the gap, and what's the future goal. I welcome over here Dr. Anil Kakri from Nepal. He's president for CMAAO. I also remember all the other dignitaries over here. Dr. Kakri, are you there for your remarks?
Thank you, Saurabh. It was a wonderful presentation, getting updates on HIV and treatment. I think this is a...
Hello?
global. I'd like to thank the speaker from ASA Foundation for our presentation. Thank you, Saurabh.
Yeah, your internet seems to be, your voice is not clear, so you're cutting off.
I said, since this is a global issues and more in our part of the world, I think this is a good presentation from ASA Foundation. I would like to thank the speaker on behalf of CMAAO, and I think we can take a few questions, if any, and I'll hand over to you.
President for CMAAO. So we will open the forum for the question answers. Dr. Monica, you want to say something?
Yes, thank you, Saurabh. And thank you very much, Dr. Alexander, for an incredible mission and work that you do, not only for your patients, but for disseminating your knowledge to other people. Very impressive outcomes and understanding and evolution of understanding in the past several decades, from treatment to post-exposure prophylaxis to preventive prophylaxis, and addressing the stigmas associated with barriers to seeking care and getting care to the most vulnerable. What also is impressive is how you prevent the disease in generational, from lateral to vertical transmission. That was an incredible example that if patients develop trust in those systems that allow them to continue care through generations, that there are ways to address treatment. And also what's impressive is how you are able to continue the work without necessary external funding, and how you're able to keep it homegrown and to help our own people with the resources that you have. My question to you, though, is where are the gaps in treating those who are vulnerable? And how are you going to make sure that you continue to give and provide the incredible care and resources that you have to continue to reach these people who might not be seeking care, not be identifying that they're at risk, or are being prevented from obtaining your care?
Thank you. Thank you for your kind comments about my presentation. As I said, if you look at that bar chart that I showed you, even today, as of 2024, there's just 87% of people who are aware of their status out of the number of people estimated to be living with HIV. So that last 13, 14% that we're not able to access are the most vulnerable. They are the ones who have been so stigmatized by the general population that they find it difficult to come out and meet health professionals or healthcare providers to get treatment. And that is where we use this combination, this three-pronged approach of involving the community itself, empowering them because they will trust their peers, provided their peers are empowered. So we need to identify leaders in that community, in the vulnerable populations, whom we can then train and empower so that they can go forth and get involved with their own community, and the community will trust their peers. That's one. The second is self-testing, because these people are hesitant to come out into the public and get tested in the public services that are available at government hospitals and in the private sector. But if they can do the self-testing, then this is something that needs to be encouraged. Governments worry that self-testing may make people who are doing it at home to be more sexually promiscuous. And as long as they know that they are not HIV positive, they will continue to be promiscuous. But that's not what we are saying. Studies have shown that self-testing, if they are identified to be positive, they need to go to a healthcare work provider. If they are negative, they need to be referred for PrEP because they have tested themselves because they think that they are at risk. So they need to then go into PrEP. So that is something that needs to be encouraged. And PrEP can be provided by the community itself once the community is empowered. And the third thing is, one is, as I said, empowering the community. Second is providing PrEP. And third is self-testing. So we need to reach out to these vulnerable communities and make them partners rather than beneficiaries. That whole mindset has to change. Many parts of the world worry that PrEP again is something that will make people take these medications and then may place themselves at more and more risk. But we have found that these drugs are effective and they do reduce the acquiring of HIV They're so highly effective up to the extent of 99%. So these are things, PrEP, self-testing, empowering the communities. These are the things that we need to do to reach out to the community. Community needs to trust us. And as they say, nothing about us without us. So unless we involve them in a very big way in all aspects of HIV care, we may find it very difficult to reach the goals that we have set for ourselves. And of course, reduce the criminalization laws that are existent in so many parts of the world, so that people will be more, they are now very fearful to come out into the open, but to get them to come out into the open and interact with healthcare providers and the communities. So these are huge challenges, huge gaps, which we need to address. And as you saw in that last slide, which shows the targets, they wanted to reduce to less than 10% of what is existing now. And that's going to be very difficult, but we do need to make a start.
Thank you.
Thank you, Dr. Alexander. We have Dr. Akhtar Hussain. Dr. Hussain, I think considering you're from South Africa, I understand that it is one of the world's largest country for the similar problem. Do you have any comments from your side of it?
Yeah, no, thank you, Sarab, and thank you, Dr. Alexandra. I think she have done the very comprehensive, excellent presentation.
Thank
And
you.
I agree with you, like PMTCT, you saying the mother and child transmission almost some places 0% or 0.5. We have 42% initially before PMTCT program start, just to
Okay.
nevaparin to the mother, pregnant mother. But since we did a antenatal viral load 0, CD4 high, then we reduce it to 5 to 2, now less than 1%. Only problem is those who escaping through the crack.
Right. Correct.
Not coming to the antenatal clinic, go to the home delivery, and those are the few. But when we used to write death certificate in neonatal baby, like PCP pneumonia, every morning, 4 or 5. Now I hardly write any death certificate in a newborn baby.
Right.
And
right.
I did a study in newborn babies at birth PCR. Those mom were on PMTCT program. I found 99% baby was negative.
Right.
So we are looking for baby to be a positive nowadays in South Africa. So there's and the other program you're running 95, 95, 95. We got 90, 90, 90 for 2030.
Right.
So I just need some concern. We involve faith-based organization because there are some stigma among them. So
Right.
how does your faith-based organization supporting your program, number one? Number two, injection lenacapavir, twice a year. What are the criteria? Who get those injections? What are the excluding criteria? Because we put all of them now fixed dose combination and they continue. We no more giving 3 tablet or 5 tablet, just
Exactly.
1 tablet. So we also thinking now start injection once in 6 months. But what are your criteria there? Thank you.
Right. Thank you so much. I would like to say that injection lenacapavir has been sanctioned by WHO only for prevention at the moment and in rare cases of treatment. This drug is extremely expensive, $48,000, even though it's just 2 injections a year. And so it's out of the reach of a majority of the world. But this has happened with all the ART that is now currently available. I don't know about pharmaceutical companies in other countries, but I can talk for India. Once the patent period for these drugs are over in the West, then Indian pharmaceutical companies begin to manufacture these drugs generically, and the cost is reduced considerably. You know, we are like 1/10 of the cost. And today, Indian pharmaceutical companies are providing 92% of the world's requirement of ART. So that is one thing. The drug still has to be developed generically and brought to India, where the cost will definitely be low. Right now, it is mainly for prevention for people in the vulnerable communities who are at risk of acquiring. Usually, we start with, there are two options for starting lenacapavir, and option 1 and option 2, where you can start the injection after giving them oral medication for some time, and then you start the injection and then give it every 6 months. The criteria really, these are fairly safe drugs. The only problem you can get is injection site reactions, where there can be little swelling and tenderness and pain, but which disappears with time, and nausea. There could be some level of nausea, but any individual who perceives himself to be at high risk of acquiring HIV is eligible to take injection lenacapavir, but it is currently not available globally, but will become available in the future. And like you, we are also giving only single tablet regime containing 3 drugs, and now we can give the 2-drug regime. And other 2-drug regimes and long-acting injections are in the pipeline, which will come out in the future. With regard to faith-based organizations, Asha Foundation is a secular organization, but I did attend a Christian conference in Asia in November 2024, and I was surprised about the amount of work that faith-based organizations are doing, especially among vulnerable communities. They are among transgender, among people living with HIV, among so many communities. They're doing incredible work, and you know, they are able to. There is acceptance without judgment, and they see every person as an individual by themselves and treat them with respect and dignity. This was something that I was very, very surprised about. And it was an eye opener for me, because I thought that they would look at this as, you know, punishment from God and all those stories that we heard 25 years ago. But they have also changed over the years. And there were about 30 organizations from Asia, all faith-based, who were involved in this conference that we had in November of 2024. And there was so much of progress in their attitudes, in their commitment, and in the work that they do. I was very pleasantly surprised.
Just to follow up, Doc, in the death certificate, cause of death, you people are writing HIV or immune deficiency disease. What do you write?
So this again is a very tricky question. As we know, nowadays, it's a little rare for us in India now to find a patient dying directly from HIV. They may die from a heart attack. They may die from tuberculosis. They may die from an opportunistic infection, or they may die from diabetes, chronic renal failure, or other causes. So that would be the primary cause of death. And in some cases, the doctors write as a secondary cause of death or other diseases that the patient had, retroviral immune disease, which may not really make much sense to a healthcare provider if they are not up to date. But as far as possible, the relatives don't want the name HIV to be there in the death certificate. So it really varies case by case and hospital by hospital.
No, thank you so much, Doc. Thank you.
In the interest of time, we are dot at 10:36. We are almost an hour of we started this session. I think I would like to thank our speaker for this most important and where the knowledge is very important for people to understand what HIV and AIDS patients are suffering from. So U is equal to U is the principle which they follow. It is not sexually transmitted to the partners. It's undetectable and untransmissible. With this note, I think I would like to thank our speaker, madam, for a wonderful session. And any message which you like to give our general audience as a take-home message before we end the session?
I mean, it's that every individual is an individual in his or own right with their hopes, aspirations, and dreams. And who are we to decide what their future is going to be? We need to accept each individual, be non-judgmental, and treat them as individuals so that they can live normal, healthy lives. Because stigma and discrimination still remains the major challenge for us to face in reaching out to the goals that we have put forth, both the global strategy program as well as us as doctors working in the field. And I also want to say that I've been working in this field for the last 30 years. And I think it's a huge privilege for me to be able to be there to see this transition from a life-threatening fatal illness to a chronic manageable illness. I think it's one of the few privileges that many people get to see. We still haven't seen that for cancer, but we saw so much of it for COVID. But here, to be able to see patients living for 28, 30 years after diagnosis, I think is an incredible achievement. And I'm very grateful for having been there during that period of my life to see this happen. So these are the two things that I would like to say. Treat every individual and respect his desires, his hopes, his aspirations, and help him to achieve those. And second, the privilege of being in this field and treating these patients and seeing the transition from a death sentence to chronic care. Thank you.
So, thank you so much. With this note, we would like to end our wonderful session. We would again meet in 2 weeks' time for yet another topic and yet another speaker. Thank you so much, everyone.
Thank you.